Good evening, everybody. We're just waiting for Director VNIT to get into the Senate Hall, and then we'll start the proceedings. Thank you. Good evening again, everybody, and welcome to this short, I'll call it a lecture and associated discussions on medical technology. I'd like to invite on stage, just when they've got settled down on their chairs there, I'd like to invite Dr. Padole and our speaker, Pratap. Please come on stage. Thank you. Okay, so we've gathered here to talk about medical technology, and I'm a mining engineer. But from an institute like VRC, I am from IIT Kharagpur. And IIT Kharagpur, VRC, whatever the engineering departments, colleges that we have in the country, and actually around the world, we are engineers, we're problem solvers. It doesn't matter what discipline it is in, but we are problem solvers. So we've gathered for this, and I'd like to give a brief introduction of Dr. Padole first, and then invite him to give a brief talk. Dr. Padole is from a place, I'll read out the name. There you go. Veer Mata Jijabai Technological Institute. We always knew it as VJTI. So it took me time to figure out, okay, this is what the place is. Okay, so he's from VJTI, and then he got his, he came to VRCE. And he's been working here since 1988, mechanical engineer. And, I met a doctor recently, and he says, of course, I'm associated with VRCE. I go and give talks in the on biomedical engineering to the MTech students in the mechanical engineering department. The reason it has happened is because as an engineer and as an administrator, Dr. Padole has looked not only inside for developing resources inside, but also associations outside of VNIT, so that the students, the staff, the institute, and the country can develop. So with these brief words, I'd like to invite Dr. Padole to the podium to give a talk. I think he's talking about engineering applications in interdisciplinary fields. Please, Dr. Padole.
Thank you, sir. At the outset, I welcome Professor Khanwilkar to VNIT, who is the distinguished alumnus of IIT Kharagpur, 1984 batch. And I was just talking to him, and he said that from last almost 35 years, he is working in Medtech field. And this is just when I was talking to one of our distinguished alumni who did his MTech from IIT Kharagpur, Dr. Raju Govardhan, and then he said that we have got a very strong alumni association chapter of IIT Kharagpur here, and his alumni is going to come to Nagpur, and why not to have a sort of a meeting over here, because he is in the area of medical engineering. So I thought, okay, and that is how this meeting is finalized. And it is more that we are here to listen to Dr. Khanwilkar, but then they said that what you are doing at VNIT, I said, yes, we are also doing little bit in the area of biomedical engineering. So I'll present that before you, and then maybe some of the doctors are here, they may express their view, or he may talk, and then later on we can have a sort of interaction about what we are doing and what further we can do. I'll just present what VNIT is doing from last about 15 years. Uh, in fact, I am the alumnus of this. I did in 1982 my BTech in mechanical engineering, and then I did MTech from VGTI, and later on I joined VRC in 88. And then it is just accident that we also entered into biomedical engineering field, and that we started with some projects in the area of dental structure, because I feel that as far as mechanical branch is concerned, it is close to the orthopedics and dental, and so this is just a coincidence when in 2000 somewhere roughly I met with one of the faculty members in dental government dental college, and that is how we started. So our first project is in the area of this dental structure, where we applied the finite element method, and that we did for the restoration of the tooth. As you know that when everything has gone, you have to restore the tooth artificially, and the main problem is there that you have to ensure that the restoration is proper, it has got sufficient strength, there is a proper retention, and also it doesn't result into excessive stresses in the other part of the body. So we studied this whole root canal treatment, and we tried to then simulate it, and then we consider some of the objectives, like how can you measure the root canal treatment, that strength of that, then the retention has to be there, and then we also consider the nonlinear property of the periodontal ligament, how it will affect the stresses around this thing. So all that we did some analysis. We consider the various materials of the root, post, and the crown, and various geometries also, and we tried to find out which one is the best. So for that we got the input from the various dental surgeons, particularly Dr. Arya work, and we come out with some conclusions. So this was the first kind of work that we did, and that is how we enter into this biomedical engineering, and we tried to apply our advanced techniques of the engineering to resolve some of the problems related to biomedical engineering. So then these are some of the conclusions. Then, and this was done by one of my colleague, and who is now professor in our department, Dr. Rashmi. That time she was doing PhD under me. Then further she continued, and she is now working in the area of biomedical engineering, particularly related to dental structure. She is working with Dr. Srivastava, who is just sitting beside her. So that legacy is still continuing. Next is then another problem was, once we entered into that, we thought that there is a problem of L4, L5 vertebra, always slip disc and that kind of thing. So we decided to analyze that, and while doing that, we come across some problem that we wanted to do the Boolean operations and other analysis if you have to enter the implant there, but then for that we required the 3D solid model of that from the CT scan report. But whatever CT scan report normally available, those are in the 2D form, and it is very difficult for us to understand. Even for the normal doctors, I think only the radiologists they can understand. So, but then whole data is there in the DICOM images. So we were that time having the one software, but then we found that that software was also giving a surface model, not a 3D that time solid model. So we decided to write our own code to convert this 2D CT scan into 3D solid model, and that we could do successfully. And for that we got the help from the SIMS. Dr. Shirish Deshpande is sitting over here. He gave us the CT scan report, and then we wrote a program and we converted that into 3D solid model. That of course the software has got all the sort of capabilities. You can zoom it, you can rotate it, and all that, and you can see the internal structure depending upon the threshold capacity, you can see only bone if you want, or skin, whatever. So that we tested also, and while doing that, we got one CT scan report, you can see here. And then when we generated that model on our screen, and also we got the physical model of that by using 3D printer, but to our surprise there were no facet joints to that, because we have taken that vertebra, and we are surprised, and we thought that there is something wrong in our program, and we took that model to Dr. Shirish Deshpande. He saw it and he said, no, what that is correct, because that was the CT scan report of the patient when that facet joints were removed and it was taken. So this is how we confirm that. So this is one thing that we did, and then we applied that to the bone fusion technique. Our model, we created that, and that is how we tried to find out and this simulate the situation of bone fusion technique, where the spacer should be, what is the importance of the pedicle instruments and those kind. So this is another type of problem that we solve. Next. So this is all that we did. I am not going into details of this thing. And then while doing this thing, another thing which we found, that if you go by from person to person, age and sex and all those things, the properties are different. Even the material properties of this weight are different, angles are different. So like that. But normally when we solve the problems of engineering, we have got a very systematic material, the properties are well known and well defined. So we normally apply the deterministic approach. But then we thought that when we are getting the properties from the journals and these things, there is a large variations, and so if you are not considering those variations, and if you are going for a specific value, then perhaps the results that which we are getting may not be applicable to that particular person. So that was a problem for us. So what we thought, because you can see even this models of elasticity, somewhere it is given 10 GPS, another one it is given 20 GPS, so almost double of that thing. Densities are different. So then we thought, instead of going for the this deterministic approach, why not to go for the probabilistic approach. So we took just the example of the hip joint. We did the finite element analysis of that, and we verified whether our analysis is correct. But then instead of going for the deterministic approach, we took the probabilistic approach. We took all the inputs as a random input, and the output were also random in form. And once we get that, this is what the detailed analysis that we did. Once we obtained those results, then we convert them into histogram and finally in the probability curve. So this is very useful while planning your sort of a the surgery, or for determining the particular material for the implants and like that, because there is a curve for the induced stress and there is a curve for the deterministic curve for the strength of that material. So if there is a sort of a crossover, then in that case there will be some combination where the stress induced will be more than the strength, and there is a probability of failure. But if doesn't happen that, then in that case the selection of that material will be suitable. So that kind of some thing we have done, and that was appreciated by the doctors also. And then another one that one of my students did, that is related to the fluid structure analysis, and we did the finite element analysis and CFD for the blood flow to the renal artery. And you know that if there is a blockage in the renal artery, then that may result into a secondary hypertension. That is what we got from the doctor. We are not claiming that thing, but there is secondary hypertension mainly because of the blockage in the renal artery, and also that will reduce the flow to the kidney. So we tried to find out the correlation between the percentage blockage in the renal artery and how much can be the secondary hypertension, because for us it is something like a blockage in the pipe. So if there is a blockage, then definitely there will be back pressure. So that kind of very simple assumption we made, and we tried to find out the relationship between the percentage blockage and the secondary hypertension. For that we created also the experimentation, that is of course with the water, and then we converted that into blood. And then for this we got the help from Dr. Mardikar and Dr. Nitin Deshpande, and I'm happy that we got the sort of a relationship between the blockage and the secondary hypertension, and out of 21 patients we could match it with 19 patients. So that is how clinically we checked also. And similarly, what will be the reduction to the blood flow to the kidney, that also we could establish. So this is another one that we tried. And then of course renal artery we have taken because that was having sufficiently large diameter. So that was the first time we were doing this CFD, and so we thought that let us go for Shepherd side, a larger one. But later on also we did it for the coronary artery. If there are multiple blockages, what will happen? So that also we did, but that is not presented here. And then the deployment of the stent, that also we tried to simulate that, because simulation of this, that was really complicated, because this is a system of which is linear and non-linear combination. We have got the stent, then balloon, and the plaque, and the artery. So many of these materials, some of materials we can consider linear, some are definitely non-linear. So we simulated that, and we tried to find out what is the optimum pressure at which the balloon should be inflated and we should put the stent, so that there is no excessive stresses which may lead to the further deposition, and it should not be under deployed, so as to avoid the migration of the stent. So that kind of work that we did, and then these are some of the conclusions of that. So these are the sort of starting projects that we did. Next. And then now that we are working with Dr. Ukhalkar, and that is related to, this is the project that we got from DST, AV fistula for the dialysis. We have to connect that artery and vein. He can tell more about that. But then the problem was that you have to ensure that the artery and vein has to be corrected at a proper angle, just to ensure that the maturation of the fistula. And for that we did lot of CFD, and we could find out that at 45 degree if you are connecting it, then the maturation of the fistula that can be guaranteed. And after doing lot of analysis, we have also come out with the device, so as to ensure that those will be connected in that particular angle. So this is the recent one that we are doing. So animal trials are going on, and once those are over, perhaps that product that can be finalized. So these are some of the projects which mainly the mechanical engineering department has done, and I am more aware of that. But then there are many other departments also who are now doing a lot of projects, particularly computer science department for the diagnosis of the various diseases they are doing. There are the electronics department, Dr. Sina, he is doing the image processing for the detections of the cancers and other kind of thing. Next. Then Arvind Kumar, again from the electronics department. So I think nowadays the image processing and using the AI and these things, that has become very sort of a common these things, because applying the electronics, IoT and the computer programming AI for the diagnosis of the various diseases. So in VNIT also there are many faculty members who are now doing these things. Professor Burshundi, yeah, next. Then Professor Kuthe is sitting over here. In fact, Professor Kuthe has got Betic Center. As I told you that IIT Bombay is having Betic Center main, Professor Ravi, who is now the director of NIT Suratkal. So Professor Kuthe, Professor Ravi, and COAP Dr. Dr. Ahuja, they are working closely, and we have got a Betic Center here. And Professor Kuthe particularly has worked with many of the doctors in and around Nagpur and the use of the 3D printers and 3D technology. So he is more aware of that, and he is helping the doctors for the surgery, for getting the proper implants and other things. Uh, then of course Rashmi, she has been working in dental and other areas. She has also come out with various implants and the tools which are required during surgery. So some of them have been patented also. And then Professor Vasevar next. Then we also come out with the startups. I was talking to you that through CIVN we have got these 4 startups which are in the area of the biomedical engineering. Then there are patents also granted. So this is just to give you idea that yes, VNIT is working in the area of biomedical engineering, and we started this somewhere in 2003 or 4, and after doing some of the works on personal sort of a contacts, then we decided to have the formal sort of forum, and then in 2013 December we established a biomedical engineering forum, and incidentally I am the president of that, and then there are Dr. Shirish Deshpande from the medical fraternity, he is there, and many more. So about 40 doctors from the medical fraternity and the engineers, they are there. We are discussing and we are trying to find out what kind of problems are there, because we are not aware of their problems, and perhaps they are not aware of our capabilities and the sort of facilities that are available at VNIT and other engineering colleges. So we have been working, and we are getting good response. Now you can see just one phone call and this thing, many of the doctors here, they are present and they are attending this. So this is in short what VNIT is doing. So once again I welcome you, sir, to VNIT, and also at the outset I thank all the doctors for coming over here, and maybe after his talk we can have more interaction and interactive session. Thank you, thank you.
Thank you very much, Dr. Padole. A wonderful, overview of all the activities that. It's so interesting to see the medical fraternity interacting so well with the engineering faculty here and coming up with innovative solutions for the problems in the medical field. I wanted to welcome all of you to this, to this program. The program is, there is a talk by Pratap, Dr. Pratap Khanwilkar, but it is an opportunity for all of us to interact and see where we can move further as far as collaborations, innovations are concerned. IIT Kharagpur Alumni Foundation, we welcome Dr. Pratap Khanwilkar, one of our alumni, to Nagpur. He is from Nagpur, so I don't have to welcome him, but to this workshop. The concept of this workshop started, as Dr. Padole said, started with a conversation and started with a discussion about Pratap's visit to Nagpur. And immediately Dr. Padole said, no, we must have a workshop, and we will do it in VNIT itself. So it was organized here. It's so nice to see so many people from the medical fraternity coming here, and they're not, they're all senior people who have been involved. I'm hearing the names, I'm seeing the names, hearing the names being announced by Dr. Padole, and I'm looking at the faces reacting to those names. And they're all names we have heard, even though we are, not in the medical field. So it's nice to see so many people come here. What I'd like to do is, we are talking about medical technology. We have medical technologists here. We have doctors from various fields here. I'd like to, invite any of you to come up here to talk about your expectations of this seminar, of this workshop, and workshops like this, because we'd like to have greater number of workshops like this, which are more, field related.
Dr. Murli, perhaps?
Dr. Murli.
Good evening. I'm Dr. Murli. I'm an orthopedic surgeon, a joint replacement surgeon, and I own two hospitals, Ayushman Hospital and Hope Hospital, a total of 150 beds. And I'm also owner of a software company, DRM Hope Softwares, which I started about 13 years back. And now that software is artificial intelligence integrated. And we have integrated AI for healthcare. So there are, we have about 50 chatbots for various use cases, for patient interaction, to aid doctors in research, to predict illnesses, and we also have various what AI does for the general public. We use that. So my pain point is I have a little story to tell. I had a friend who was a radiologist. His name was Dr. Chadi. He was a radiologist in Government Medical College, Nagpur. He was my batchmate. And I remember about 1 year back, he had severe pain in his abdomen, and he underwent a CT scan. He was a renowned radiologist, and even his seniors used to ask him for opinion. But when he took his CT scan, he found everything to be okay. And within a few weeks, he died of CA pancreas. Now, CA pancreas, any general surgeon would tell you, it's very, very difficult to diagnose in an early stage. So my request is there any solution for diagnosing CA pancreas at an early stage? I would like to make an effort and see to it that, like my friend, Dr. Chadi, we are able to save more patients. So that's one use case. And there are a lot of wearables in the industry right now. There is smartwatch, smart ring, there are continuous glucose monitoring. So I would like to know whether how we can integrate it so that people in rural areas and tribal areas, how can they be benefited? So these are the two things.
Good evening. I'm Dr. Dhananjay Ukhalkar. I'm a nephrologist. And the first time that I heard about industry and engineering and medical fraternities coming together and solving a problem was from Dr. Mahurkar, a 1971 batch person who settled in US as a nephrologist. And he helped design a lot of path-breaking devices which were instrumental in changing the way nephrology is practiced. He came to Nagpur and he showed us all those that he had done collaborating with an engineer. So I kept on wondering, if they can do it in Chicago, why can't we do it in Nagpur? Why can't we have collaborations between medical fraternity and engineering fraternity and try and solve a problem? So Dr. Oriopoulos also collaborated with an engineer in Canada. They came up with CAPD, number of examples. My expectation out of such an activity is, can you share with us the framework in which engineering disciplines and medical disciplines collaborate in the United States or in Canada? Thank you.
Hello, good evening, and I thank Padole sir and Rashmi madam for calling me here. My association with VNIT and Biomedical Engineering Board is more than 20 years. And basically, I came here because Padole sir, Dr. Peshwe were my family friends. So out of one day, I had a query and I just asked Padole sir, ki, I have this problem, how do I solve it? Because I need a engineering or technological help. So he directed me to Dr. Rashmi Uddanwadikar, which from there we started our friendship. And I can also say that I share a patent with Dr. Padole, where we have determined the tongue and palate contact, because during swallowing, there's alteration in the pressure, especially those people who undergo surgery or those people who have speech problem. There's a difference in the tongue to palate contact pressure. So that was the first indigenous device where we would sit together and then discuss the problem, and then we would come out with the ideas how to solve the problem. So that was one patent. Later on with Rashmi madam also, we have developed a lingual model and how to, I'm an orthodontist. So basically I treat teeth, I make people look handsome. So it will help me make people look handsome without the braces appearing outside. There's something called as lingual braces. So understanding the biomechanics, I took help from Dr. Rashmi Uddanwadikar madam. And currently, the most difficult, like most people who are suffering from TM joint disorders, we have that TM, 70% of people because of the excess stress in life. So we are working on the model, how the biomechanics of how the dynamics of TM joint is altered and how we can help with the help of splint. So we are working on the project related to that. My experience till now has, that the only difference, we all think, but we are thinking differently. Probably it is necessary that we have a common language. The language used by health workers are different. The language used by technology people are different. So if we can harmonize the language, it will be, we can be doing multiple marvels. So with AI based, there are certain things which we do not understand. We need to locate, I need to locate the articular disc and have the image. As sir said, we had the image, but we did not know how to locate it or how to identify it. So we had to take the help of engineers. So whenever Rashmi would call me to take a session for their engineer, I would say, doctors have idea, engineers have the skill. So if we combine together, probably we'll be also creating wonders. Thank you.
I am Dr. Puneet Jandal, working as a cardiac surgeon. I also happen to work with Dr. Albert Starr, and that is where, see, he said that in 1960-61, Edwards came to him with a model of artificial heart. And then he said that the more people were dying because of the valves. That is how the Starr-Edward valve came into, and that was the first clinical mechanical heart valve which was implanted by him. So when I was coming on the way here, I was just thinking, I read about your artificial heart, and I think now you are working on how to miniaturizing it. So I was just thinking, like, now most of the cars have got those wireless chargers. So if we have that totally implantable artificial heart, and if you have a wireless rechargeable mattress, something like that. So maybe you just lie down, sleep, and your battery is recharged for the next day. And I think another thing, the mechanical heart valves, some research level at that end has gone down a little bit. I would still look forward to some mechanical heart valve coming in which doesn't require anticoagulation. That would be the valve for future. Yeah, we look forward to that.
I welcome this idea of doctors and engineers coming together. About 10 years back, I'm an intensivist. So we get into a lot of calculations and we started making apps. So I have about 20 apps which are world's largest used apps on critical care. And there are about 310,000 users across the globe. Then on when COVID came in and when we saw so many people dying of ventilators, that's where we made India's first non-invasive ventilator. And they've been used more than 300 places. And then so many other things. And the challenge basically is that, we have brilliant technical support in the country. There's no question about it. Making devices is a challenge. And we have about 11 devices which have been made and have been produced in industry. The issue starts as calibrating those and someone ascertaining that they are delivering what they are supposed to. I've struggled a lot in this area. And nobody would courageously come, yeah, Satish, this is what is delivering, and we certify this. And I think this is where the trouble really is. Why do we need an FDA certification? Is it that we don't have someone who certify this? And it's mathematics. Unlike medical field, you say that my device is delivering 21 centimeters water pressure at a flow of about 15 liters. But unfortunately, there's a big struggle, very big struggle in this area. We presented our devices across the world, and everyone in the rest of the world would appreciate this is a fantastic device. The trouble starts is somebody should say, and we have to have an association which would say yes, or otherwise say no, this is not delivering it. But no one would do that. And I think this is what we need to. I really feel there's a tremendous potential in our country. In COVID time, we made 11 devices. Literally no one, literally across the globe had done that. And they have been, I presented this across the world. All of them are surprised that this is done in Nagpur. But if you have an agency which says, yeah, this is it, we would submit it to you and say it yes or no, whatever. And that is the only way to go ahead. We have superb, like VNIT, we have been working with teaching students from MUHS, training them at young age to understand the gas laws, the flow dynamics, and they have been very good faculties. So our association with VNIT, with MUHS was great. Dr. Padore and Rashmi have been very proactive. But across the country, the trouble is there should be an agency which says what you say is been delivered or it has not been delivered, whatever. And this is where we are lacking. So my suggestion is we must meet, otherwise Indian entrepreneurs and people like us would suffer. It's been years that I've been working and I've worked with a lot of people, and fortunately I've connected fairly good places, but no one there to say, yeah, this is what it delivers. Thank you.
Good evening, everyone. I'm Dr. Vidula Kapre. I'm anesthesiologist, and I joined slightly late. But what I gather from what I heard so far, I think we are taking inputs from doctors about what they would wish to have in future. Is that it? Okay. Sure. Okay. So ours is a ENT and head and neck center, privately owned, and we do a lot of cochlear implant surgeries for small children. Unfortunately, they tend to be more from the poor socio-economic background. So although the government gives aids for the implant and there are schemes, because now technology and sciences is so advanced in India, so I hope that we could be able to manufacture good quality indigenous implants, so that it is not, right now the very, very basic implant begins at 6 to 7 lakh upwards. And although the government ADIP scheme, initially it provides the basic implant, which of course is of not that good quality, and later on if at all there's something goes wrong with the processing unit or whatever, even that recurring expenditure is a big burden on the family. Secondly, we are using medical laser, carbon dioxide laser for last, since 1990s, early 90s, which is of great benefit for our specialty. And now lately, with all endoscopic microlaryngeal surgeries, we are able to deal with early stage, 3 stage up to laryngeal cancers. So we can avoid a major operation where the person loses his voice box. And now medical laser started off in Bhopal. My father, he was scientist at National Physical Laboratory, director grade, and he was instrumental in starting off that field. But later on, we would like to have some compact and good quality lasers, which should not be that expensive, which we are now importing from Germany. So these are the two things. And also, sorry, but if at all laryngectomy is performed, there is a prosthesis valve, which I think is pretty simple to my mind. It is fitted on the food pipe after the larynx is out. And it is through the one-way movement of air from that valve that the patient is able to speak. Again, I feel that maybe we don't need to import that kind of thing, which again, after a big operation, is another huge expenditure for the patient. Thank you.
Yeah. Good evening. I'm Dr. Kanchan Vanere. I'm Deputy Director, Health Services, Nagpur Division. Everybody is talking about advanced technologies, but being in public health department, I will stick to basics. So whenever I take review of maternal mortality in my division, I myself is a gynecologist. So sadly, you know, we could reduce our maternal mortality like from 250 to now it is 33. But when I take review of this maternal mortalities, sadly, most of the deaths are due to anemia. So is there any way we can develop a, technology, a wearable device we are talking about? So these poor women from tribal districts, they can wear it and we can monitor from the district hospital so that they are tracked, because many a times they come only for one checkup. Later we cannot find them. That is one thing. Secondly, my friend Dr. Murli, he's working on teledoctor, AI integrated. But because mental health is also very close to my heart, so is there any AI integrated teledoctor that will be able to give counseling to, because nuclear families nowadays, work pressure on the youth. So, many a times they are not going to the doctor or counselor. So they can do their counseling with the help of teledoctor, which is integrated with AI. So that will be a, fantastic thing to do. Thank you.
Pratap, you have your work cut out for you. I don't need to speak. And Dr. Padoli, this is the second time we are in a gathering where the audience is asking for setting up a center where we can monitor, we can certify, and we can classify things, right? We had it at the Air Force also. We had it in our workshop in IIM, and now here as well. So I think it's an opportunity I think we need to explore together. And I'm happy that IIT Kharagpur Alumni Foundation has been present in all 3 occasions. So I think there is something, for us in that, right? Okay. Lovely to have so much participation from the audience. I would now like to request my senior, Dipankar Moitra, to come and talk a little bit about medical technology. Like me, he's a mining engineer, but my wife is a lawyer, his wife is a doctor. I think that's where he gets medical technology into his life. Thank you. Come.
Good evening, Dr. Padole, Pratap, all distinguished guests over here, all eminent doctors, everyone over here. So to maintain continuity of this event, we started off with a lecture by Dr. Padole about what is happening in VNIT in the region. Then we invited some doctors to voice what are their expectations. I would like to say something about what is happening in India in this field, in this domain. After which Pratap takes over the mic and he talks about his business, like what is the thing he's doing and all. So I'll start off with this thing, I got to read because the Indian healthcare market has been witnessing double-digit growth in recent years. However, our healthcare system is paradoxical. On the one hand, it boasts the best-in-class healthcare delivery, attracting medical tourists from across the world. And on the other, it is characterized by a near absence of accessible, affordable, quality health services for a large part of its population. Existing infrastructure, especially in smaller towns, rural areas, is inadequate to meet the ever-growing needs of the Indian population. Less than 10% of the population is covered under health insurance, and India has less than one-third doctors per capita compared. Now, adding infrastructure and medical professionals alone will not be able to solve India's huge unmet needs in healthcare. It needs to be supported by technology. An effective and innovative use of medical technology has the potential of increasing access, significantly reducing the burden of disease and the load on healthcare delivery services through early diagnosis, better clinical outcomes, less invasive procedures, and shorter recovery times. Currently, the market for medical technology in India is small, but rapidly expanding. It is nascent and highly fragmented with limited indigenous manufacturing. Imports constitute over 75% of the projected estimate to reach $8 billion in this fiscal year. Revenue is expected to show an annual growth rate of 8%, resulting in a market volume of $12 billion by 2028. However, the industry has been stifled by some key impediments to growth. The foremost among these is the lack of affordability, accessibility, awareness, and availability. A key question, therefore, is how to increase penetration of medical technology to improve health outcomes in India. I'm sorry I have to read this because this is very detailed. The answer lies in innovation. Medical technology innovation can be the tool to make modern care accessible, available, and affordable to all by lowering the cost of the product or delivery. Innovation need not only be restricted to products. Business model innovation across the value chain with manufacturing, distribution, marketing, etc. and frugality can often generate significant benefits to all stakeholders, including patients and end users. For innovation to make an impact, collaboration between the stakeholders in the medical technology ecosystem is a key success factor. However, what can perhaps be the biggest opportunity for improvement is an ambiguous regulatory framework with no distinct legal status for the medical technology industry, which has been acknowledged as a key constraint for the industry. By ambiguous, I mean the government policies should be very open, they shouldn't be very restrictive. Now, what is happening is evolving government policies over the years has been a big boost for the large medtech providers, and many have used this scheme to launch new manufacturing facilities. For example, Wipro GE Healthcare is in process of building a large medical device manufacturing factory in Bangalore. Siemens Healthineers started its new computed tomography scanners manufacturing facility in Bangalore. Many projects have been approved by the government under the PLI scheme. PLI is, Production Linked Incentive Scheme. Yeah, Production Linked Investment, including Philips Global Business Services for MRI coils, etc. It's very heartening to note that the Union Cabinet chaired by our Honorable Prime Minister approved the National Medical Devices Policy in April 2023. Accordingly, PLI scheme for support for setting up 4 parks in Himachal, MP, Tamil Nadu and UP have already been implemented. A total of 14 projects producing 37 products have been commissioned, including linear accelerator, MRI scan, CT scan, mammogram, Siam X-ray tubes, etc. The healthcare sector in India is thus being continuously enriched with increasing demand for novel applications and increased integration of transformational technologies like machine learning, AI, cloud computing, IT, and advanced imaging. Several companies have either been striking deals or associated with global medtech companies to streamline services and expand business. There are currently more than 4,000 medtech startups in India. An interesting partnership development in India is between Amazon Web Services and Government of India in healthcare innovations like CDAC's e-Sanjeevani OPD program. As you know, CDAC is the premier R&D organization in Ministry of Electronics and IT, tasked with strengthening India's tech capabilities by developing and deploying world-class tech solutions. We thus are quite confident that our great nation will establish itself as a world leader in medtech in the coming years, given the abundance of talent in this domain, and especially through guidance of internationally recognized world leaders like Dr. Pratap Khanwilkar here, in addition to active business and government support. Thank you.
Thank you very much, Dipankar. Lovely overview of what the requirements of the country are. And, again, I was just standing there and thinking about all the things that we've been hearing and how much more work there is for us to do. So I'm glad that I'm never going to retire. I'd like to now request Dr. Arghya Mitra from VNIT to introduce our guest for the day, and we'll talk about, introduce him and invite him to talk and give his talk. Thank you.
A very good evening to all of you. I'm privileged to introduce today's center of attraction, Professor Dr. Pratap Khanwilkar in front of you. Dr. Pratap Khanwilkar is a distinguished alumnus of Mayo College, Ajmer, and the 2023 recipient of its prestigious JTM Gibson Award for Alumni Excellence. Dr. Pratap graduated from IIT Kharagpur in Electrical Engineering in 1984, after which he obtained MS and PhD in Bioengineering and MBA, all from University of Utah. He is an elected fellow of the American Institute of Medical and Biological Engineering and has been the recipient of many international, national, statewide and local honors and awards. Dr. Pratap is a healthcare ecosystem builder, organizational entrepreneur and medical device innovator with 40 years of experience. As the founder CEO, he currently leads Ignition Key LLC, a leadership and management consultancy to advance healthcare. He consults with academic institutes, startups, early stage growth companies, and individual innovators. Dr. Pratap has started, led, and invested in 18 medtech companies, with 3 exits, and has contributed to medtech and entrepreneurial ecosystem development not only in the USA, but also in Canada, South Korea, China, Japan, Australia, Europe, and now in India. Dr. Pratap is an active angel investor individually and with San Antonio-based Alamo Angels. From 2014 through 2022, he was the Vice President for Product Development at Incube's Lab, a Silicon Valley-based medtech incubator. Incube Labs is one of the most successful medtech incubators in the world in terms of translational outcomes and success rates. 16 exits with only 3 failures in its 26-year history. He co-led its San Antonio, Texas facility and directed its expansion, initiating new projects and advancing present ones. He has significant experience and accomplishments in translational research, entrepreneurship, and commercialization. Prior to Incubes, Dr. Pratap was the founding Culture Translational Research Program Director executive in residence and professor of bioengineering at the University of Pittsburgh. He led Pitt's Coulter program to nation-leading translational outcomes, startups, and licenses. He also developed commercialization courseware followed by Pitt, by the San Antonio Medtech community, and by the National Institutes of Health for prospective small company applicants for NIH support. Dr. Pratap has founded 17 for-profit companies and 1 non-profit. He led MedQuest Products as CEO from sole proprietor to private corporate startup to acquisition by publicly held World Heart Corporation. He transitioned WHRT to its next generation product line. He also built up and helped consolidated WHRT operations in Salt Lake City, Utah. He is an inventor on 7 issued US patents. He has clinically introduced or commercialized each invention from one of the most sophisticated medical devices, a long-term multi-year implantable left ventricular assist device, LVAD, the LVACR VAD, which is fully magnetically leviated for end-stage congestive heart failure, to a disposable surgical electrocautery blade. Pardon me if I'm pronouncing wrongly. He has also contributed to the development, clinical use of other breakthrough medical technologies and devices such as reabsorbable magnesium for orthopedic implants, next generation implantable neuromodulation for neurodegenerative conditions such as spinal cord injury and multiple sclerosis, and novel drug delivery system such as a next generation iontophoretic patch for iron deficiency anemia, and a breakthrough oral biological drug delivery system platform presently in clinical trials for a variety of conditions. Dr. Pratap also serves as an adjunct visiting professor at the University of Utah and Pittsburgh, as well as at IIT Kharagpur and IIM Nagpur. Apart from his education and professional achievements, he is a keen enthusiast of nature and of outdoor activities like hiking, bicycling, triathlons, and photography. He designs and makes bolo ties, one he is wearing right now. He has co-founded Social Justice Advancement in the Texas Hill Country and directs wild tiger and related habitat conservation efforts in India initiated by his daughter. We are really very grateful to have you, sir, with us today, and now the stage is yours. Thank you. Thank you all.
Well, thank you so much for having me. It's truly an honor and a pleasure to be here in Nagpur. I frankly did not expect this level of activity and accomplishments that you all have already made in medical technology, so that's fantastic to see. It has far exceeded my expectations, and thank you so much for the organizers, IITKGP, Alumni Association, VNIT. It's great to see the clinical community and the scientific community interact. That's the key step for successful medical technology development. And I will talk about a third leg of the stool as well, which is the business side. So in my view, and I'll mention this before, it's a 3-legged stool that has to have those 3 legs to stand up. Medical, engineering, and science, and business, they all have to work together to make successful medtech work. So without further ado, I will start on my presentation. I'm sure I'll be available at the end to interact with you, ask all kinds of questions, get your comments, get your contacts. I have lots of business cards. We should get in touch. I'm spending about 4 months of the year here in Nagpur now because of family reasons. So yeah, I'll just get going. I have 4 key things to talk to you about today. One is just about medical technologies I've been involved with. It's already been mentioned. I'll give you a little bit more in-depth flavor what that means. And then the nice thing is when I started on this path about 40 years ago, even my professors in IIT Kharagpur had no clue what biomedical engineering was. So I'm majored in electrical engineering, I would say 99% of my class that went to the US went this way, and I'm the only one who went that way. They thought, oh, you're going to go and learn how to repair hospital equipment. I said, well, maybe I will, but I want to do something better than that as well. So most of my classmates are in Silicon Valley doing hardware, software, IT stuff, and I'm here. But the nice thing is, in 40 years, we have learned how to make it a discipline. In my day, it was learning by doing, learning by experience, making all kinds of mistakes, which I still do. But now we have a discipline of medical technology development. We know how to do this in a systematic way. And that's great to see this field evolve to that. I'll mention the future, how I see it, maybe, both from a US perspective, and maybe then talk about opportunities I see in India, and some of you have already alluded to that. So without further ado, the pictures on the slide, the one in the middle is an artificial heart. That's the reason I went to Utah, is because Utah developed in the early 80s, before I went to graduate school, the Javik 7 heart, the world's first permanent implantable heart, was developed in Utah by the University of Utah, commercialized in Utah by a company called Symbion, and then put into a patient at the University of Utah Hospital, Dr. Bonnie Clark, who happened to be a Seattle area dentist in '82. He didn't survive for very long, about maybe 112 days, I think, had a few strokes, but he knew it was an experiment, if you will, and he deliberately chose to help advance the technology by essentially volunteering to get that implant. So that's how I went to Utah and studied under, some of you may have heard of Dr. Willem Kolff. He was the father of artificial organs. He invented dialysis. He invented the enteric balloon pump. He played a part in inventing the cochlear implant. So I had some good gurus to work under in Utah. So on this side is my device, an implantable LVAD, a left ventricular assist device. How many of you are docs in the audience? I just want to get can you raise your hand? All right, quite a few. How many are scientists and engineers? Oh, great. And business people? And you can be both, by the way. Yeah. So the left ventricular, I worked in Utah at the university for about 6 years trying to do the next generation of the Javik 7 artificial heart, a smaller version, because this kind of has these tubes coming out and you've got to have a pneumatic compressor operate the thing. It was not a very mobile system. But we soon realized, designing an artificial heart is a very, very hard problem. So we kind of defaulted and came back a little bit the field and said, hey, let's think about a left ventricular assist device. So we leave the natural heart in place and we kind of build a booster pump for the left side, because the left side is typically what fails. The left ventricle, if some of you who are not docs remember, that does 80% of the work in the body because it has to pump the oxygenated blood through your body. The right side is along for the ride. It just takes the deoxygenated blood coming from the veins and pumps it through the lungs so the blood can get oxygenated. So typically we support the left side. About 80% of the patients in heart failure can make do with just a left-sided support. So that's why the whole industry has moved to a left ventricular assist device. So basically you see that, and I'll talk a little bit more about it as well later on. I won't belabor this. Luckily I went to Utah, and Utah is beautiful for outdoors. I learned how to ski downhill. I learned how to raft rivers down Whitewater. I learned how to climb mountains in the area. So my first, after I got my MBA and my master's at the time, of course I was super cocky and thought I knew everything there was to know about everything. So I sometimes there's a saying, right? Fools rush in where angels fear to tread. So in early '92, I put, I'd spent about 6 years at the University of Utah. We founded a company to go for an implantable, fully maglev centrifugal pump as an LVAD. So there were 3 groups at that time who started on this path of a full maglev centrifugal pump. One of them, not mine, is the winner today, is the Abbott HeartMate 3 device, which is the only device now standing for an implantable LVAD. But because of outcomes, they've shown through clinical trials that it works better than any other technology. So we picked the right platform, the right architecture, right topology 30 years ago. So there was a Japanese group, which was eventually became Terumo Cardiovascular, working on it. There was us in Utah, and then there was a group in Switzerland, which eventually led to the HeartMate 3 device as well. So, you know, when you think of, typically bioengineers look at nature as the inspiration, as a source for inspiration. But in this case, that's the reason I like to talk about this, is sometimes nature actually leads you astray. Because when people first try to build a blood pump, they try to mimic nature. They try to make a displacement pump. They try to make something that expanded, filled with blood, contracted, expelled blood, which is like how birds fly, right? When people try to build airplanes, they try to build airplanes with flapping wings, and that didn't work so well at all. So the rotary pump, there was actually a doctor, Rich Wampler, who really showed, and he's an engineer too, as a side, who showed that you can directly pump blood safely. You can actually have a spinning turbine in the blood to pump blood reasonably safely. So that kind of opened up the whole field of rotary pump, direct pumping of blood. You don't have to try to squeeze the blood or whatever. We could just directly have a pump that pumped blood. So the first pumps were like the propeller plane, like, you know, it opened up the aviation industry. So the first pumps were based on mechanical bearings and this high-speed pump that was spinning at about 10,000, 15,000 RPM. It worked reasonably well, but there were still issues. The third generation pumps were the hydrodynamic pumps. So I'm using kind of technical language, but basically using blood as a suspension mechanism like a helicopter does. The helicopter has to spin its wings to lift off. So they were using the hydrodynamic properties of blood as a suspension medium to kind of lift their impeller off. So, for example, there's a device called the Heartware HVAD that was recently withdrawn from the market that depended on this principle. So it didn't have mechanical ball bearings, but it had this, it depended on, again, this helicopter effect to have the spinning part be floating in blood. But as you well know, someone alluded to the great variation in patients, right? You can, especially in heart failure, you can get hypovolemic patients, people who are low on fluid. You can get hypervolemic patients, so the viscosity of the blood varies all over the map. And so to design a pump to meet all those sources of variation was too hard. And so we decided early on that, hey, we are going to go for centrifugal maglev, kind of the next generation of pumps. And you know, it was a risky bet. I mean, there were many times we thought we would fail. Luckily, we didn't. So we designed a pump, and again, these are some of the patents I have with many others, is the simplest maglev, because maglev can be very complicated. You've heard of maglev trains. There's a maglev train that goes from Shanghai airport to downtown Shanghai. It's completely levitated. But those are big things. You know, the challenge was, how do you shrink that into something that you can put inside the body? So we figured out, it took us a while to figure that out, how to make it into a pump compact enough that you can put it inside where it is supposed to go. And then, of course, once you design the pump, it's not a product or a solution yet. You have to put electronics and software and user interfaces and all that stuff that makes it a product. So that was the thing that we did. Sorry, I also want to point out that this was a full support LVAD, meaning it could generate about 8 to 10 liters of flow. We wanted the late-stage, end-stage heart failure patient to be out and about, go and play golf, go for even for a jog at those cardiac liters, basically restore them to a reasonably normal quality of life. Then we had a project that came along in which we developed pump now. This is also maglev, that is the small of a AA battery. But the reason we can make it this small is because A, we had learned a little bit about maglev here, and then the flow requirements for this is for people, kids who are born with congenital heart defects, infant toddlers, about 1.5 liters. That's enough to get them past the initial stuff. But of course, I had to then also sell it to my board saying, hey, there's a bigger market of somewhere between here and here. This is a pump that we are, actually I'm just getting ready to take to market our clinical into patients right now at up to about 3 liters a minute of flow, which can then support the less sick patients, heart failure patients. And it's been brought to my attention. I was at Narayan Hridayalaya 2 days ago, meeting with Dr. Devi Shetty and his team, and the heart failure cardiologist said, hey, Pratap, you can actually use it in the smaller Indian men and Indian women who don't need 8 liters a minute of support. Maybe this pump at 3 liters a minute can be fine for even late stage heart failure. So we'll see. So my corporate journey was, I started something in my garage, really to access some government grants to get things going. I formed this company, which was a spin-off of the University of Utah, much like you have spin-offs from VNIT and others. Utah has a very robust entrepreneurial ecosystem. One of the world's first research parks was developed in Salt Lake City by a very pioneering dean of engineering there in the mid-60s. Then I sold it to World Heart, which is a public company. I left World Heart in about 2010. That was bought by another public company called Hardware. That was bought by Medtronic. If you're successful, that's how the food chain goes, right? You start something, and if it is successful, a bigger company eats you up, and so on and so forth. Medtronic, just to end the story, acquired Hardware for more than $1 billion 2016, and in 2021, because the Hardware was this hydrodynamic, this helicopter-based pump, they couldn't compete with HeartMate 3. The clinical outcomes were much better for HeartMate 3, so they said, hey, we can't compete with them. And that's another story, of course. That's a corporate story. So I raised about $35 million to take my device from an idea to patients we did first in humans in Greece, in Europe, and then I sold it to World Heart, and the whole goal was to acquire more capital, because in my business in class 3 implantable devices, it takes about $150 to $200 million to get through FDA approval. It's especially in the US now. I have some ideas of how to do it, maybe less expensively in India. That's one of the ideas that I'm pursuing here right now. So we took it to concept. We started a bridge to transplant trial in the United States while I was there. But the pediatric device, we did chronic animal studies, and then Hardware and Medtronic didn't want anything to do with it. So right now, the same guy who was at Carnegie Mellon is now at Cornell University. He's an endowed professor, and I'm working with him on a NUCO now to get a new company going to commercialize this technology. So just to give you an idea what the process is, right? The surgeons are here, clinicians. The first thing is, does it fit where it is supposed to go? So we had to design that. First we did computer modeling, but then we did X-ray. This is actually the shadow of a HeartMate 1 device. The pulsatile device I was telling you about, the generation 1 device. You can see how large it is in a patient's chest compared to ours. So we did a little bit of those radiographic superimposition studies. Then we actually, one of my founders was a cardiac surgeon who did heart transplants and LVADs. So this is why clinical collaboration is critical. So I was the founder, CEO. I was kind of the techie business type. I had a technical person, a PhD electrical engineer who was the hardcore techie person. And we had a biomedical scientist who was a founder of Symbion, the Jarvik 7. So we had a good team of multidisciplinary people. who were the founding team. And again, that's what you need, I think, in my experience to do this. So I'm very glad to hear in this room how you guys are already doing that collaboration, because it's critical. If you don't do that, forget it. As the chances of success are like 1%, if you will. So we had a sterilized model of a pump, non-working, just sitting, and had approval from the hospital. So anyone who came for a heart transplant or a LVAD could sign up to be evaluated first with this model, so we could see whether it worked or not, the angles and the implantation technique, all that stuff is so critical for the implanting team. So of course, we talked about, Dr. Pillari, you talked about finite element analysis. We did a lot of that, both for computational fluid dynamics, how does the blood behave, and we want to make sure the shear stresses are low enough, and the transit time is low enough that we are not shearing blood cells, because we can pump red liquid, but if we are shearing the red blood cells, there's no point in it. So we have to design it so that the blood cells are happy or not as stressed, let me put it that way, as it goes through our pump. Then, of course, we did flow visualization. We seeded with red RBC side particles. We shone a laser on it, and we just had a transparent model built. In parallel, we had to do the magnetics design, because after all, it's got a motor in it, it's got a maglev in it. We had to make sure that everything worked, even from a thermal analysis. We didn't provide hotspots, so it would fry the blood or activate the blood when it was flowing through the pump. So we came with a model, and we spent about a year putting this whole multidisciplinary optimization model together. And within a year, we had a model that then we took within 2 years to clinical. So I wasted about 7 years of the early part of my company's existence. We had to throw out the whole bloody design because it was not practical. It would have to have a wire this big coming to the skin and all that stuff. So we had to start from scratch. My investors were not happy, but they still let me continue as CEO, I suppose. Then, of course, you had to test it on the bench. So we developed a simulator. This was simulate the left ventricle, the floppy atria, put the pump, and then we could use that for bench testing to simulate different heart failure conditions, different degrees of natural heart ejection fractions versus the dynamics of the flow, because now we are talking about a pulsating heart and a continuously flowing pump. How does that work with the flow rates? Then we put systems together for life testing. In the US at least, one of the accepted animal models is calves. So we use calves for our chronic animal testing. Of course, we would monitor the calves every day, but more importantly, we would open up the pump, look at the kidneys, because in the calves, if the pump may be clean, but if it's throwing off some micro clots, they'll end up as the kidney in the calf, but in the human, it'll end up in the brain as a stroke. Don't want that. So we did animal testing, then we went to Greece. We got approval from the Greek Ministry of Health. We got approval from the ethics committee of the hospital in Greece that we did this first ever implant of. This is we designed a trial to get our answers quickly. So that's another thing, you have to design your clinical trial in a smart way, because we didn't want to put in a pump and leave it there for years and then 3 years later get our answers that we wanted. We wanted answers faster. So we designed a trial for high-risk MVRR patients, and we would promote recovery. Of course, they would have informed consent, and we are able to recover both patients. We just did 2 patients in Greece just to confirm, hey, does our pump human blood safely? We had done like 60, 70 animals by that time. So that's the critical thing. So you can see, I'll show you some animations here this was pre-operative, the first patient's heart, as you visualize. So imagine this to be the visualization of the left ventricle, and it's kind of beating, but it's floppy compared to what it was after we got done. with our LVAD support, you can see how leaner it has become and how more vigorously it's beating. So we went from ejection fractions of about 10% to 45-50% normal. We took the heart out because you think about it, your heart never, ever since your fetal heart starts beating in your mother's womb, it doesn't stop. It can't stop. It stops and you die. So this is like one of the first therapies that can unload your heart, take the full load at the beginning, but then slowly load up your heart again to be like a physical trainer for your heart. So we did that successfully in Greece, and that was a good way for us then to start thinking about a longer term trial in the United States. So we did that. I'm going to talk to you about one patient. Again, it was great for me to close the loop. I'd come to Utah because they'd done the whole Javik 7. The sound, please. I don't know why it's not showing up. Anyway, it's about this patient, who came to the University of Utah Hospital, was enrolled in the trial. Yes, I believe so. That's okay. I'll skip it.
A nurse listens to Doug Wiley's heart and hears a finely tuned machine.
Low pitch motor.
Because that's what's in it.
I didn't have this, I might not be sitting here right now, and it's cool.
Wiley has a condition that was weakening his heart and slowly killing him.
Feeling just terrible. I mean, you get up, you don't want to do nothing. You gotta make yourself do everything. You're just drained of energy.
And that's all you want to do is sit on the couch and watch TV.
He needed a heart transplant, but those are in very short supply. So he went to University of Utah Healthcare's Cardiovascular Center to see surgeon Craig Seltzman.
And so we had the conversation with him and said, well, you can keep waiting and keep getting admitted to the hospital, or, while you're fairly stable right now, let's go ahead and put this pump in and get you back to living, and then we'll get you an organ when the time comes.
And they mentioned VAD, and I was like, what's that?
A VAD is a ventricular assist device, a pump surgically implanted that helps the heart move blood.
So this sits right into the inflow, so it flows out of the left ventricle into the pump, through the pump, and then back out to the rest of his body.
VADs have been around for years, part of the rich history of cutting-edge heart research.
This was one of the originals.
But the devices keep getting smaller.
This pump is super small, right? It's like a C battery.
And better. Wiley is the fourth in the nation. The Levitt.
Doug was a couple of days away from dying, basically, when he came here.
Bringing it back a little bit and saying, okay, now, since our success rate is so good, let's make people live
We use two batteries.
while they're waiting for an organ.
Now they're improving the lives of patients like Doug Wiley.
You have less people dying from advanced heart failure because we have these kind of tools.
2.5 weeks after surgery, Doug Wiley's really moving again.
I think it's great. I think it gives him another chance.
She's got her husband back.
Yeah, really. Got my husband back. Chance to live again. It's awesome.
But the ultimate goal, Seltzman says, isn't to replace a sick heart.
The holy grail is not to have a machine in you, but get you through sickness. Give therapies that have yet to be discovered or can be tested so that you can get the thing out of you.
To apply some of the university's cutting-edge research and nurse ailing hearts back to health.
Yeah, it's just a slight hum. Just
No doubt Doug Wiley likes the sound of that.
So, because it's a continuously flowing pump, it doesn't produce a pulse. We had to train the nurses to say, okay, patient doesn't have a pulse, but they're doing fine. because that's typically what nurses do, look for the patient's pulse. So he was drugged 6 months later in Idaho at home, enjoying a picnic by the lakeside with his family and doing wheelies on his motorbike. He's still wearing his, this is the strap that holds his electronics and batteries. So it's like, Doug, don't crash, you're going to die, dude. But he didn't, thank God. But yeah, so that was the intent of these technologies, is to bring people, restore them to a normal period of life. I'm going to talk about something else that I've done lately. This is with a gentleman who's the founder of InCube, which is again, the most successful. He's from Hyderabad, by the way. He's also Indian American, much smarter than me. He's got about 500 patents in this field. So, always meeting someone who's smarter than you, thank God. The nice thing about InCube, I joined him is because I want to do other things. So we developed this really holy grail of drug delivery for oral delivery of biological drugs. So if you think of biological drugs, they're big, complex, long molecules that if you do it in pill form, the stomach will do to it what the stomach is designed to do. It'll chop them up into small molecules to digest them. So, because for drugs, I think at least in the Western countries, about 8 of the 10 best-selling drugs now are biological drugs. So we developed this technology. I was part of a team. I was not the main guy. I was part of a team here that we took this concept all the way from animal trials, early clinical studies, and then we had an IPO on the NASDAQ for at that time, $500 million market cap a few years ago. It's low now. But I want to show you how this works. It's really a device that is disguised as a pill for the delivery of biological drugs. So the patient swallows it. It's in a house in a capsule. So right now, biological drugs, you either have an injection or an IV to it. So because the stomach has a pH gradient, we are able to design the coating of the capsule so it doesn't dissolve in the acidity of the stomach, but it dissolves in the acidity of the small intestine. So once it dissolves, you basically produce carbon dioxide and water, naturally occurring substances. The water, of course, is emitted. The carbon dioxide inflates this balloon, and then this needle, which is loaded with a payload of choice, whatever, and it could be a sugar needle. Sugar can be made really sharp, and then it embeds in the gut, which is highly vascularized, meaning lots of blood supply to the gut. And the sugar needle dissolves, it releases the drug, and therefore the drug is then available. So you're basically being injected from the inside out, but you can't feel it. The reason you can't, bonus points is you can't feel it is because you don't have any sharp pain receptors in your gut. You can't feel that you're being poked from the inside out. So we are in trials right now in Australia for various things, and it's still going. So I hope that works out well. Just to give you a flavor here, I know my blurb talked about the Autom electrocautery. We developed a titanium nitride coating, which I patented, co-patented, actually as a material, a biocompatible material for the blood pump. But then we realized, hey, we can actually do, typically metal is deposited as in crystalline structure, but we were able to deposit it at near room temperature in an amorphous structure, so it could bend without breaking or cracking or whatever. So we realized that, hey, maybe the docs could use it for electrocautery, because right now you can, you guys use stainless steel electrodes that you dispose of for cutting tissue. I mean, the knife is only used for the outer skin, but once you get into deep tissue, you use radio frequency energy to get deeper and cut better. So there's a Teflon coated blade, but because this would be an electrical conductor as well, because Teflon is an insulator. So there would be no plume coming out and all that stuff. So I got it approved. Unfortunately, we were pretty naive about the market. We didn't know how to actually address the market. We were focused on a blood pump, And we was like, I actually had some surgeons in India and the US and Japan try it, and they liked it, but we thought it was worth more than it actually was. Our pricing point was too high, basically. So then we kind of gave up, and our investors by that time said, hey, focus on LVAD, man. That's the way to go. I also had a part to play in orthopedics. So this is I've done different projects in orthopedics, but bioresorbable magnesium. So basically, the landscape and materials used for implants, orthopedic implants, hasn't changed for 50, 60 years. It's stainless steel alloys or titanium alloys or plastics. So basically if you have a broken, people talked about TMJ, and I worked on a TMJ project, extracellular matrix for TMJ. If you have a broken bone, you have this plate and screw. You put on a plate and then you screw in to keep the two parts of the bone together. Once that bone heals, though, you need to take it out. Because if you keep the artificial plate taking the load, the bone will never heal properly. So you need to go and then take that metal implant out. So you've got to have two surgeries, one to put it in and then one to take it out. So bioresorbable magnesium, and now it's being commercialized by two companies in Germany and one in the US, has the advantage. We can, of course, people way smarter than me did metallurgical, alloy development, all that stuff, is we can control the rate of degradation. So in the beginning, we can have it provide the strength of metal, which the bone needs, the full support. But over time, it can degrade away and basically be bioresorbed. So then at the end, it's gone. And then over time, the bone, the natural bone, has time to absorb more and more of the load, which is what it needs, really, for better healing. Iron deficiency anemia, it's a big problem, I know, in India. It's a big problem in the US as well. So you can take oral iron, right? I mean, I can go to a drugstore in the US or India and get pills, iron pills. But about half of women, and 80% of the population is women, can't tolerate oral iron. They get GI issues. So it's for those people that we designed this iron to ferritic. Basically, we had a salt of iron that then we can give electrical charge to push the drug through the skin. That's really what iontophoresis is about. And we had a proprietary form of iontophoresis. So I was the CTO for this company, and kind of the FDA killed it, if you will. Then I worked on another neuromodulation product that is really the next generation of neuromodulation. It's an implant, and it's to restore basically Superman, right? Christopher Reeves, he fell off a horse, and he was paralyzed for life. And he couldn't function. He had spinal cord injury. The biggest problem that spinal cord injury issue people have, besides, of course, they can't move, is peeing. Because you'd have to do it 6, 7 times a day. And what they have to do is to stick a catheter up men and women to empty the bladder, which creates all kinds of problems. So we developed this implant and proved that it works in animals. We didn't take it to people. We had an FDA application which can then restore bladder function on demand. So basically, your peeing function, our peeing function there's 2 phases to it. One is the bladder relaxes, it fills up with urine, and then it has to switch to when you want to go and pee, the bladder has to contract, and then the urinary sphincter has to open. So these 2 things no one had ever done before enable 2 different muscle groups to be controlled with one implant. So we have a patent on that as well, and we have achieved lots of milestones. So what are the lessons learned? Just stepping back and saying, I think you guys know that. You've got to have the unmet need coming from a clinician. You got the solution coming from a scientist, bioengineer, and you've got to have a business person orienting it. How are we going to get it out there? How are we going to get money? Because if you don't make money, you're not going to get investment. I mean, it's as simple as that, unless it's funded by the Gates Foundation for some use, and that's very rare. So those 3 things have to be satisfied. before we get it to patients. So typically, although what happens is you have a technology, especially in academia, and they're trying to figure out which markets to get to. But what I've learned over the years is start backwards. Start with the end in mind. That's where the clinicians come in, saying what are the pain points. You guys have pointed that out. And then work your way backwards, because if you do that, you have a much better chance of connecting the dots that are needed. So, there are lots of dots, and they get very expensive. The clinical trials gets very expensive. That's the most expensive part. The regulatory part gets very expensive. Then before that, you have to do the animal testing and the bench testing. Then before that, you have to do the product development and the manufacturing. And of course, the technologies that come into it. So essentially, of course, then the financing process goes along with it. And typically, at least in the US, you can get funding from the government, non-dilutive funding for this early part, but here you need to get external financing because the size of the zeros increase quite a bit once you get into that stage. And of course, you have to have an appropriate organization, team, operations, relationships as you go through this evolutionary process. So, nothing revolutionary, if you will. You got to go after a real market. You have to make sure that the market is really there, not only top-down analysis, but like bottom-up, talking to clinicians, talking to the people in the value chain. You can't just make up numbers. Excel spreadsheet, it's easy to get carried away in an Excel spreadsheet, and everyone, I've never seen any investment pitch which doesn't have a hockey stick, right? Who's going to say, oh, my market is going to flatten out really well? No one says that. Everyone is like, hockey stick. No, that's not real. You know that. So as an investor, I've learned to be very, very skeptical of hockey sticks. A founding team, have these people been there and done that? I mean, a lot of you have, who came and said, hey, I've got all these companies, fantastic. You've been there, done that. You don't have to be coached right from the get-go how to run a medical business. Are they coachable? Are they willing to listen to others, right? And of course, in the US, a defensible IP model is critical. I think anywhere in the world now. And the risks. So that's just another way to look at it. You guys on the medical side, you're well-versed to thinking about risks. That's what you think about when you treat a patient. How do I manage the risk so that the patient can have the best outcome? Sometimes us on the inventor side, damn the risk, full steam ahead. But we have to kind of train our thinking to be risk managers as well. So what is the future? I've been asked to talk about that. I'm not a very good crystal gazer, I think. The way I do it is, look at the trends, right? Look at the demographics, look at the economic trends, look at the, especially health and wellness, epidemiology, disease progressions. I mean, nowadays there's so much understanding of the immune system that xenotransplants are now a viable option again. I know the surgeon in Baltimore, Maryland, a heart surgeon, Dr. Bart Griffiths, who's implanted the first 2 pigs, heart in humans. Those bioengineered pigs organs are being used for kidney transplants as well. But so that's coming back again. The microbiome, 10 years ago, if someone from Harvard, actually, a dean there of the medical school asked me, Pratap, you should pay attention to the microbiome. And I was like, what the heck is a microbiome? I don't even know what are you talking about. But now everyone knows that, we are actually carriers for the bacteria. There are more bacteria in our gut than there are cells in the human body. They just prefer to keep us alive because they can be alive. That's really who we are. So that's a humbling thought, by the way. The gap analysis, right? How does care delivered? Someone mentioned about accessibility and affordability of care, especially in the Indian context. I think there's some big innovations that can happen there. And then bottom up is just, what are the tools, right? What are the tools that are being developed? Just yesterday I read on LinkedIn that one of the first CRISPR therapies has been approved by the FDA. So that is someone that, the Nobel Prize was won by Jennifer Doudna just like 5-6 years ago, and it's already out there making waves, getting therapy out there. So I think the time scale has reduced as well, from when a technology is discovered to when actually is being used for human health. So that's something that we have to be aware of. There's so many great technologies, omics technologies, augmented reality, virtual reality, especially for training and education. I mean, that's a fantastic tool to do that. I could just go on and on. So, the question then becomes, so what? I mean, how do these trends, these are major trends, and someone smarter than me has drawn this mind map of, hey, how do you take, let's say, individualization and health? So I look for the intersection of these trends. Where do these trends intersect? Maybe there's opportunity there. There's, lots of people like Frost & Sullivan is a global healthcare marketing. They do all kinds of market analysis. They come up with reports of what's hot. Something that makes sense to me, especially in the US healthcare system, probably in India as well, is health at home. Why should the patient go to the hospital? Why should the patient go to the clinic? Everything should come to him or her at home, right? That's the best. We are comfortable at home, or, if we are treated appropriately. So I can imagine a day, I'm a, thinker, I dream, you're diagnosed at home, you have the diagnostic capacity at home, no big deal, use your iPhone, use a supplement to your iPhone. You can 3D bioprint your medication at home, whatever you need, it's contained the APIs that generally you need, or it can be printed in the nearest pharmacy, and a drone can drop your customized medicine when you need them. Your medical, the pills are commercial trials, clinical trials are done on the average population, right? I mean, you take 10,000 patients and a clinical trial is it. But for me, with my phenotype, my genotype, my microbiome, when should I take this pill? What should it be made of to make me, to help me the most, right? Personalized medicine, if you will, right? But everything is there. Everything is there, and it's moving towards that. Now, maybe in the Indian context, it's a kiosk in a village, right, that does all this stuff. No home can afford point of care stuff like what I'm talking about, but it can be done. I mean, I think why not? So that's kind of one of my things that I'm thinking of. Then I think, we are entering the age of biology versus I design machines, widgets. But biology, we have such great understanding of how the genome works and cells work and all that stuff that, as I referred to the pig, we can bioengineer a pig to get us the organs instead of a mechanical heart, for example. I'm going to be a dinosaur really soon, and that's okay. So looking at the big picture, I'll close out in a few minutes here, is if you look at global health, it's aging population all across the board for the most part. It's the chronic diseases, and those are like a twin tsunami, right? That is coming to India, has already come to India. I see that in everywhere I go, all the cities I go, all these huge number of hospitals, clinics, labs, because the need is there, and it's going to grow multiple times as well. So healthcare spending is increasing rapidly. The population, the global population that is aging, so that's why you see the flattening, if you will. And for globally, so if you look at disease states, this is from 1990 to 2019, non-communicable diseases, NCDs, are what's taking over. What used to kill a lot of Indians, right? When I was born in '62, I think the life expectancy in India was maybe in the mid-40s, maybe, or something like that. Correct me if I'm wrong, please. But for sure, I know my uncles and aunts, I mean, they didn't expect to live beyond 55 for sure. And now, living longer, and the non-communicable diseases are taking over. We have solved, for the most part, the problem of the communicable diseases, or at least they're a less proportion of what they used to be. And in my field, cardiovascular diseases, the global burden of diseases, by far, cardiovascular diseases where things are having the most impact. So in India, when I look back, and I won't belabor this, I've helped people all over the world, regions in the US, countries start their medtech ecosystems. I think COVID was a big eye-opener for India because we realized that, hey, even though we export about 50% of the world's biosimilars, biogeneric drugs, we import about 75% of our medical devices. So we better do something about it. So I'm glad to see that there's a consensus at all levels of government, right, from the union cabinet onwards, all the way to regions like Vidarbha, who are saying, hey, we need to do something about medtech. Because it's coming, right? I mean, even though we boast that we have one of the world's youngest population, we should use the democratic dividend and all that stuff, this thing is going to shift up in 10 years upwards, right? People are going to go older. You're going to have more older people supported by less younger people. It's already happening in China. So demographics is destiny. Health opportunities, you see the change from NCDs to, from communication diseases. 1990, diarrheal diseases was the leading killer. Now it's number 3, heart disease, which was right here, number 6. Quickly has become the number 1 killer in India. And of course, we know the reasons for that. And I would add the environmental factor. Our water quality, our air quality. Indians have heart failure about 10 years younger than equivalent in the West. I think because of these environmental factors, we just get end stage, get sicker quicker because our environment is not supportive of good health. I think you alluded to affordability, access. These are key challenges that we have. But it's doable, right? I mean, unless as we are getting together here to say, hey, how can we solve it? So my vision is that India can be the medtech hub for the world. Just like the IT industry is, there's no reason why, right? We have the clinicians, the world-class clinicians, the world-class healthcare facilities. We have the world-class scientists. We just put Chandrayaan on the dark side of the moon. Technically, we can do stuff. We have the management talent. We can do this. So that's kind of my field. And I've gotten involved with Indian projects at IIT Kharagpur. I just met with Dr. Trehan and his staff at Bangalore. I just met with Dr. Murthy again, Mr. Murthy of Infosys fame. So we want to make it happen. We want to make this vision happen. I'm involved with a project out of Hyderabad for a CPB pump with Indians and Americans as well. As we mentioned, I'm involved with IIM Nagpur. I'm teaching entrepreneurship course, but I'm also helping Dr. Metri, along with Dr. Dio here from Reliance. We're designing a course for entrepreneurship, innovation, venture creation that we want to launch in July of next year. I mentioned the baby heart, so to speak, the baby LVAD. I'm exploring how to make it in India, use it in patients in India, and then use that as a launch pad for commercializing in the rest of the world as well. So, I've learned to dream big, but have your feet solidly on the ground. I think great people and great teams make good things happen. That's the critical thing. In this business, it takes a village. I mean, that's why it's great to see all of you here, the clinicians, the business, the engineering, the biology, even the government, to work together to make it happen. It's just a too complicated enterprise not to do it otherwise. You have to make the effort to really understand how you're going to do it. In my view, fundraising is the most difficult part. It takes lots of capital. You will have your luck, and you can, and it can play against you. It can help you. Timing is also there. Late failures are a feature of the business and not a bug, as the software people like to say. Because I can do all this stuff, spend 15 years on a project, spend in the US, 50, $100 million, and I can still fail. I can get clinical trials approved, and then I'll find that I didn't test it in a small segment of patients that have an adverse reaction to whatever I've did, and we have to start all from scratch again, or fail, or take it out of the market. So it's just it's fun. I like variety, I guess. So it's a combination of sprints, triathlons, which I do, steeplechase, and snakes and ladders. I didn't know before this that snakes and ladders was invented in India. So you suddenly get to the 99 spot and suddenly the snake eats you and down you go to 0. That's sometimes how it works. I think opportunity for Nagpur is there. Central location, catchment area for all of central India is there. It's a growing logistics hub, as you well know. I'm glad to see all the key elements of the infrastructure are in place. There's obviously work to be done. Gaps need to be filled, especially on the the skilled labor side, to make this device, make it an industry that works. I'm going to explore from my US university, the University of Pittsburgh, how to maybe collaborate with institutions here to grow the skilled workforce here in India as well. But it'll take some vision, persistence, collaboration, all that stuff. And I have to say, my ancestors have done it. My great-grandfather, Dada Saheb Dhanwate, came to Nagpur as a poor, struggling lithographic artist and made Shivraj the biggest and best printing press in all of Asia in its heyday. Now it's a different story. And my grandfather, Baburao Dhanwate, on the maternal side, he helped Nagpur also develop on the business side. So I have deep roots in Nagpur. I want to see Nagpur succeed, and hopefully as a team we can do this. So thank you for listening, and appreciate it. My social causes, by the way, are wild tiger conservation and women's rights in India as well. Any questions, or how do you want to? Yeah, please.
We are fortunate to have Sashikant here. He's an angel investor, also a VNIT alum. So we would like to explore his expertise in setting up a Medtech hub in Mihan, which was being proposed by VED for some time, Vidarbha Economic Development Council. But there has been no movement about it. So Sashi, you're the right person. You're an angel investor, you're the technical person, and of course we have the international expertise here. So what are your views on that? Like, do we get rolling right now, or do we hold on for some time?
I think all ingredients are right here, and great support from Pratap, Khanwilkar sir. In terms of he has seen end-to-end 9 yards in terms of right from the.
I failed quite a few times.
But you have gone through your journeys. A lot of people, as many doctors who were mentioned over here, in terms of creating those technologies, but then getting this technology to a commercialization phase is where most of the people are struggling over here.
Correct.
And we have got this incubators, we have the initiative at VNIT, then we have got this Medtech incubator in the Raisoni also. So we already have one of the incubators which is supported almost like 4 crores of rupees and investment being done. And I think one of these things which is going to happen in 27, 28, 29 in January, the Advantage Vidarbha, where Nitin Gadkari is proposing some of those initiatives on almost like 30 tracks. And one of those tracks is going to be the medical and this space. And he would really love to form a kind of a think tank in terms of how to take this medtech innovation. And this could be led by the Advantage Vidarbha Forum also. And that's a continuous process. Okay. And we can use the good offices of Nitin Gadkari because he has given us a blanket permission that whatever the kind of things you want. And
of course, I've heard great things about Gadkari from all over India when I visit. That's
right, right. So he says that if any thing is needed, and if you need to get into something and call and get help of some of those people at the top, he is ready to help. So that's going to be initiated on 27, 28, and 29.
Unfortunately, I'll leave back for the US on the 13th, but I hopefully
but next
remotely
time
or something we can
come.
take part. That'll be great. Yeah, fantastic. That's good to know.
With technology,
your
physical presence is no longer a requirement, right? So
some of the time, yeah.
Physical presence is no longer always a requirement.
That's true. That's true.
So you know, maybe we look at an opportunity to be a part of this Advantage Vidarbha with your presence from wherever you are. Okay. I just like to add a few things. I mean, I've been looking through this, and all what I learned in engineering is going through my head. Okay, all the fluid dynamics, all the finite element modeling, things that I didn't do well at, things that I did well at.
Me neither.
Okay. So it's wonderful to see how you have applied that in biomedical engineering and done well. Okay, so shall we have a big round of applause for Pratap and his talk?
Thank you.
I'd like to now invite Madhukar Meshram to give a formal vote of thanks. Oh, sorry. Sumit has a question.
Myself, Sumit Gatewar, IIT Kharagpur 2010 batch, Mechanical Department, specialized in Manufacturing Science and Engineering. I had a question for you, like what prompted you to pursue Medtech or bioengineering instead of having an exemplary career in electrical engineering at IIT Kharagpur?
Yeah, sorry. I have to say, sorry, all the docs, I knew early on I didn't want to become a doctor. Why? Because of the whole cutting of the frog thing. That kind of said, okay, now I cut up humans with no problem, with abandon. But back then it was a barrier. So actually I spent about a year and a half in Nagpur. My dad was in the army. My mother, of course, is from here. I got rheumatic fever as a teenager. A lot of people get rheumatic heart disease in India. And I was just lucky enough to come here and be, our GP actually misdiagnosed me. And, but there was another doc, I think he's passed away here, Dr. Mukherjee, who was a great doc. The minute he saw me, he's like, get him in a wheelchair, don't have him move, bed rest for months. And so that really helped. About 4 months of bed rest, if you will, really prompted me to think about the medical side of things. So, looking back, it's kind of obvious, but back then, I think that was one of the influences. Then I did 8th grade in BCS in Bishop Cotton School because of that. I was with my grandparents, and they made sure I didn't get in too much trouble. So I think that kind of laid the groundwork for me to be sensitive to poor health and how it affects quality of life at a very early stage. And when I got into engineering, it just one thing led to another, I guess. So that's my answer to. Yeah. Thank you.
Good evening, everyone. I am Madhukar Meshram, 1979 pass out from IIT Kharagpur in electrical engineering, and I am honored to be given this opportunity to thank all of you. It has been a great honor to be a part of this unique and wonderful event. On behalf of VNIT and IIT Kharagpur Alumni Foundation, Nagpur chapter, I would like to extend my heartiest gratitude to Professor Dr. Pramod Padole, Director VNIT, without whose guidance and cooperation, this event would not have been possible in this prestigious institute. I would like to place my gracious gratitude to Professor Dr. Pratap Khanwilkar, our fellow alumni from IIT Kharagpur, for accepting our humble invitation for today's event despite his extremely busy schedule, and to share his exemplary and priceless contribution in the field of Medtech. I am sure through his crisp, vivid, and intelligible talk on various innovations and developments, which includes a string of patents, as he has mentioned in the course of his talk today, we all must have benefited in more than many ways. I'm profusely thankful to him for being in our midst today. We have a galaxy of luminaries from different fields of medical sciences based in Nagpur. I express my sincere thanks to all of them who have taken out time from their busy schedule and graced today's event. We are equally honored to have in our midst the distinguished alumnus. I think Dr. Ramesh Jain is there? Yeah, sorry. Dr. Ramesh Jain, 1969 VRC graduate. I think you prefer to call VRC instead of VNIT, I believe. In electrical and electronics engineering, PhD in computer science in 1976, Emeritus Brent Professor at University of California in Irvine, and a distinguished associated faculty at Ashoka University. He is an entrepreneur, researcher in transforming health using lifestyle and environment. Thank you, sir, for being with us today. I also take this opportunity to thank our senior-most alumnus from IIT Kharagpur, based in Nagpur, Mr. Shiv Sharma, for being present in this august audience. Mr. Sharma graduated from Kharagpur in 1966 and has been the leading light of our alumni activity at Nagpur over the decades. Thank you, Dada, for showing us the way despite your not very good health for past couple of days. Thank you very much. At the end, my sincere thanks to the deans, departmental heads, faculty, researchers, students, entrepreneurs, and the esteemed guests, many of whom perhaps physically not available, perhaps because of their some exams going on today, and because this is going to be streamed live, and later on also it's going to be uploaded on YouTube. Perhaps that is the advantage of the present day technology. Nevertheless, we thank all of them and extend our heartfelt thanks to the support teams of both VNIT and IIT Kharagpur Alumni Foundation, Nagpur chapter, who meticulously planned and executed the event. Once again, thank you all, and request everyone present here to kindly join us for the high tea outside the Senate Hall. Thank you. Pardon? Yeah, arranged by VNIT, and thanks for being an excellent host. Thank you very much. Thank you, sir. Come. Thank you. Thank
you. Let me just wrap up my computer and stuff. I'll be there.